My name is Dev Mitra. I'm an emergency physician at Alfred Health. And today I was talking about the optimal management of an aggressive, agitated patient in the emergency department. We briefly went through the epidemiology of aggressive patients in the department. The evidence on it is quite limited by underreporting, underpublishing, and a variable methodology to collect the data. But the best estimate we have is that emergency clinicians experience somewhere between 30 and 100 episodes of aggressive, violent patients per 10,000 presentations. The numbers appear to be higher in the USA and UK than Australia, at least according to current reports. The most common cause of aggressive agitated patients, again, remain unknown, but among the broad groups of medical conditions versus psychiatric conditions versus drugs and alcohol, it appears that a vast majority of our current population who are aggressive or agitated are under the influence of drugs and alcohol. And these are a wide variety of drugs and alcohol. Alcohol is the most commonest co-ingestant in an aggressive patient, but we also have stimulants, methamphetamines being the most common, as well as benzodiazepines. In managing an aggressive agitated patient, an interdisciplinary team approach is what should be used. At the Alfred Hospital, we use a behavior of concern team, which consists of clinicians, doctors, nurses, a psychiatric assessment team, and sometimes a pharmacist in conjunction with quite a heavy security presence. What we've observed more recently is that the verbal de-escalation and the presence of the team alone is often not adequate to control the aggression from such patients. And physical and chemical restraints are more and more commonly being required. With regards to chemical restraint, the evidence is quite varied at the moment. A combination of benzodiazepines and antipsychotics such as droperidol or haloperidol have been shown to be effective in quite a number of randomized controlled trials. But there is emerging evidence, mainly from observational studies, that ketamine may be most effective in managing the aggressive patient in a short period of time. We look forward to further trials in this area to establish an evidence-based approach to chemical sedation in such patients.